They can join in the middle of the process here. So, just going to talk about head injuries and acute intracranial bleeds. We'll go over a little bit of physiology and then more assessment stuff, and then how we take care of them. And I threw acute bleeds in here just because as far as just the head injury bleed management is kind of all the same. I shouldn't say all the same, but it's similar. So I kind of threw a little bit of that in here as well. So physiology, some of the things we'll talk about is the Monroe-Kelly doctrine, and that's kind of the basis of what's going on inside our heads. Cerebral perfusion pressure, what it is and what we do with it, and primary and secondary injury. And then I'll talk a little bit about how the brain auto-regulates itself as well. So the Monroe-Kelly doctrine, kind of, inside of our head we have the brain itself. Takes up about 80% of the space. Cerebral spinal fluid takes about 10%, and blood is about 10%. And so what the Monroe-Kelly doctrine says is, and it's pretty common sense, if one of those, for instance, brain tissue swells, then these two have to decrease in order to have enough room in there. If we have a hyperemic state, where we have a lot of blood flow for whatever reason, injury, fever, whatever, and a little bit of swelling here, then something has to give. So the brain tries to balance itself out, so there's a finite space in there, obviously about 2 liters worth, and so when one of those goes up, the other ones have to go down. Well, John, welcome. Come in, sit.
Can I eat?
Mm-hmm.
Sit next to you, Jordan?
Yeah. Yeah, I'll just scoot over.
So just going over a little bit of physiology first, and then some assessment stuff and management. Oh yeah, there you go. Thank you. Thank you. So in a nutshell, the Monroe-Kelly doctrine, hypothesis, whatever you want to call it, says that when whatever's in our head, if one part expands, then the other parts have to decrease. So if our brain swells, we have less blood or less CSF, or all of the above. So cerebral perfusion pressure is just the pressure that is in our head, allowing blood to flow in there. And it's pretty simple. It's just our map minus the ICP. And so we like to keep our normal ICP somewhere between 0 and 12. We like to keep our cerebral perfusion pressure definitely above 50, but preferably above 70. So again, if our ICP is up, then we try to get the map up to keep that cerebral perfusion pressure where it belongs. If it gets below 50, that's where we don't want it below 50. If you have it below 50, you just kind of have a passive flow. There's no real pressure that's able to perfuse the brain. Primary injury is what happens to our patient before they get here. I think we're all pretty familiar with that. Motorcycle rider without a helmet downstairs, somebody dives off Tubbs Hill, whacks their head, they blow a gasket and have a big subarachnoid bleed. Whatever it is, that's our primary injury, and there's not a lot we can do about that. But what we can have a big effect on is a secondary injury here. And secondary injury is a result of ischemia, inflammation, cellular inflammation, increased ICP, hypoxia, hypotension. All of those things, either individually or in a combination, cause more secondary injury. After an injury, there's an increased metabolic demand, and so your brain is screaming for help. One thing about our brain tissue is it has no glucose stores, and so it needs a constant supply of glucose and oxygen, obviously. When those get interrupted or limited, then the brain has nothing to fall back on. And so what happens to any cell in our body when oxygen and glucose supply is interrupted, what does it do then? What kind of metabolism does it convert to? Yeah, it goes over to anaerobic metabolism, and then you get lactic acidosis, which does what in the brain? Causes vasodilation. So our ICP goes up more, and we get more swelling, and it just becomes a big vicious circle. We could spend a couple hours going over the inflammatory response and the effects of hypoxia and ischemia on the brain, but suffice to say that secondary injury is the big thing that we need to intervene in and hopefully limit as much as we can. A couple different ways that the brain tries to keep all of that from happening. The first way it does it is with the metabolic pathway, and the brain responds to PaCO2 levels and hydrogen ion concentration. So if you have a high CO2 or high hydrogen ion concentration, that equates to what? It's acidotic. And so the vessels dilate. Increases cerebral blood flow, which to a point it's a protective mechanism. Tries, it's not a bad thing. Get rid of the lactic acid, bring more glucose, bring more oxygen, hopefully correct things. But in a patient that already has a lot of swelling up here and a limited space to expand, it's not necessarily a good thing because it just causes more swelling and in the end more hypoxia and more ischemia at the cellular level. There's an inverse relationship between pH and cerebral blood flow, so again, acidosis, more blood flow, alkalosis, the blood flow decreases. Now we used to use that a lot, the alkalosis there, we used to use that a lot by hyperventilating people. I mean, you guys know that, which was great. It works, decreases ICP, but they don't have any blood flow. So unless it's an emergent situation, I mean, somebody's going to herniate right in front of your eyes in the next 2 minutes, we really don't use that anymore. So the other way the brain kind of regulates itself is in response to pressure. So when the MAP goes up or down and the cerebral perfusion pressure goes up and down, then you have an increase or decrease in vascular diameter, allowing more or less blood flow. So if the pressure, if your MAP goes up and you've got a really adequate cerebral perfusion pressure, the vessels are going to constrict a little bit so that it just keeps a normal blood flow, and vice versa. And all of that works as long as we have a good MAP and a good cerebral perfusion pressure. If we don't have that, then it just becomes kind of a wash, and it gets to the point where it's just a passive flow. Literally, you could pick your patient up by the feet and blood would run in, stand them straight up and blood would run out, but there's no pressure gradient to push it back and forth, if that makes any sense. Now, all of this, the pressure response, the response to the metabolic pathway, all of that in you and I, sitting here healthy, takes place in 1 to 3 seconds. Boom. We sneeze, ICP goes up, that particularly the pressure side of the equation, our brain auto-regulates just quickly. Now, if you have a patient that's injured, has increased ICP for whatever reason, that response might take 30 seconds, 60 seconds, or even more to even start to take effect. Now the problem with that is during that 30, 60 seconds, cells are dying because they don't have any blood flow. And so when you think of it all the way to that level, to the cellular level, that every incidence of increased ICP and decreased blood flow or nutrition to the brain, every time that happens, brain cells die or are damaged. And so, it doesn't take too long, and pretty soon second grade's missing. And so again, going back to that secondary injury, we need to try to limit that as much as we possibly can. All right, a little bit different physiology stuff here. Some of the herniation syndromes that we see, and there's 4 main ones. There's a subfalcine, central, uncal, and tonsillar. And subfalcine, this is called the false cerebri here. A little piece of dura mater that goes down in between the hemispheres. Subfalcine is the most common type, and we'll talk about that. You get a lesion here and it starts pushing brain tissue underneath that. Can't go through it, so it kind of shoves it down underneath there. Uncal herniation is when you get a lesion and just one side, usually the temporal lobe, starts to shove down through the tentorial notch. This is the tentorial notch here. You get just one side shoves down through there. Central herniation here is where there's enough pressure that everything is kind of shoving down through that tentorial notch. And then the tonsillar herniation is down here at the foramen magnum, where we've put enough pressure through the tentorial notch that it's pushing on the midbrain and starting to shove down through there and pushing on the pons and the medulla. And we'll talk about all of those and different symptoms that you'll see. Just another picture here of some subfalcine herniation. You can see the midline here. You've got a big bleed and a huge midline shift. And that's just really shoved over underneath the false cerebri there. So subfalcine herniation, that's the most common thing, most common type that we're going to see. And usually when we see this, it's kind of just a precursor to more other types of herniation. If we're able to stop it there, that's great. And usually we can have a fairly decent recovery, but most of the time, if you get to this point, particularly if it's a pretty significant midline shift, then you're going to see other types of herniation as well. And with this, you might see a lot of different symptoms, from simple irritability to sleepiness to all the way to coma and posturing, or everything in between. So this is this type of herniation can be fairly minor all the way to devastating. And this is just another image here of the subfalcine herniation and the uncal herniation here. Gives a little bit more of the tentorial notch gives a little more graphic to the. So uncal herniation is the second most common type that we see. Usually the inferior temporal lobe gets shoved down through the tentorial notch. And then it starts to push on the midbrain and even the brainstem a little bit. And so when we get to this point, that's where you're going to start seeing changes in respiratory pattern, more pupillary changes. The posterior cerebral artery is more frequently involved here, and that gets impinged or pushed. So one of the things that you may see because of that supplies a third cranial nerve. And so one of the things that you may see if your patient is awake and able to verbalize anything, it's doubtful that they will be, but you may be able to assess a change in visual field just because of that getting affected. The other thing that you're going to start to see because of the pressure on the third cranial nerve is you'll start to see the pupils dilate. And with uncal herniation, the one-sided herniation, you're only going to get one pupil that dilates. If you get to the point that both pupils are dilated, that's when you're progressing to central herniation. More and more stuff is pushing down through the tentorial notch. What you'll typically see with your pupillary changes, how they progress, is you'll see dilation first. You may still get some reaction, but the pupil will be dilated. Then you'll lose the reaction, and then what you'll see next is kind of a down and outward gaze. The pupil will be fixed and dilated, and the pupil will be down and looking outward. The reason that you see that progression is because the third cranial nerve, the parasympathetic fibers are wrapped around the outside of the nerve, and on the inside of the nerve itself is where the motor fibers are. So the sympathetic and parasympathetic response is what dilates and constricts our pupils. So that's the first thing to go, is that parasympathetic response gets squeezed. And then as it squeezes more, it impinges the motor function, and that's when you get the downward and outward gaze. So you can actually watch the progression of increased intracranial pressure just by watching your patient's pupils.
Towards the lesion or
It's usually down and out. So the pupil, the affected pupil, is looking down
or
and
just
out.
the one?
With uncal herniation.
Yeah.
You only it's typically
Same.
it's typically just a unilateral pupil effect. Central herniation, again, is where we start just pushing more and more of the brain down through the tentorial notch, and there's more and more pressure on the midbrain and the diencephalon, increasing, decreased level of consciousness, and now is when we're going to start seeing dysrhythmias, particularly bradydysrhythmias. You're going to see a significant change in respiratory pattern, and the pupillary changes that you're going to see here are going to be bilateral. And they'll progress the same way as the other ones do, where first it's dilation, then dilation and fixation, and then the downward and outward gaze. But when you have bilateral pupil changes, it's it's kind of intuitive, but that's when there's more and more involvement in the brain stem and down through that tentorial notch. The other thing that you may see, and this is just kind of, it's not really need to know for us, but it's just kind of interesting to know, if you ever see it on a CT report, the mention of direct hemorrhages, that's a pretty significant amount of pressure down onto the brainstem, because it starts to tear the small vessels in the brainstem, and you'll actually see these little direct hemorrhages on a CT, and they're kind of a star. I mean, they're very, very small, but if a radiologist happens to note them, that's just another indication that there's been a lot of pressure on the brainstem. And I just like this picture because it's kind of cool. But this is the diencephalon, and so you'll get more pressure from here, and that pushes down on the diencephalon and the midbrain here, and then that's where it starts to push down farther and farther on the brainstem. So it's just kind of a graphic of where your patient's being affected there. I just thought it was a cool picture. Tonsillar herniation that's when we're getting down to where things are probably going to end pretty soon. It's where the cerebellum is pushed down through the foramen magnum and starts to put pressure on the brainstem and the medulla. And this is where we get Cushing's triad. So you guys know what Cushing's triad is? All right. You get a widened pulse pressure, and bradycardia, and irregular respirations. Yeah, you get ataxic respirations, actually, where just a very irregular pattern interspersed with periods of apnea. So when you see that, things are kind of getting down to where we're not going to have a good outcome. What I have seen fairly typically, and you guys chime in here if you've seen anything different or if you've seen the same thing. Once we get to this point, we're looking at the patient's probably going to die. And what I've seen is you'll see that Cushing's triad. The pulse pressure will start to widen, and they get bradycardic, and then all of a sudden you may get just like that. They have a heart rate of 180, and their pressure is 210. Their systolic pressure is 210. And it's just kind of the body's last ditch gasping effort to perfuse the brain, and then they die. And you obviously don't see that every time, but it's not uncommon that you see that kind of response. Have you seen that?
Once or twice.
Yeah. Yeah, it's not uncommon thing, I don't think.
Usually somebody we're waiting to people.
Right.
It's gonna happen in
To donate.
organ donation, yeah,
Right,
unfortunately.
Yeah.
Unfortunately, the way wherever how you look at it.
Mm-hmm. Exactly. So some of the other signs and symptoms that we'll see, we call it abnormal flexion and extension now. We all kind of grew up, I think, with decerebrate and decorticate posturing. I'm kind of dumb, and so it took me forever to remember what decerebrate and decorticate was. I always had to really think about it or go look it up. Yeah, I finally figured out it's decorticate was toward the core. Yeah, yeah. But I'm a slow learner, so it took me a while to remember that. So I like abnormal flexion and extension because I can see that. The abnormal flexion or the decorticate posturing is not as bad as extension and decerebrate because usually that's just kind of a lot of swelling in the cerebral cortex, and you may see that kind of posturing pattern. When you get to the decerebrate or the extension is when it's worse because that's when you're really starting to push on the midbrain and disrupt all the connections between the brainstem and the midbrain and the cerebral cortex. So if your patient progresses from decorticate or flexion to decerebrate and extension, then you can tell that that's an extension or an increasing ICP that's pushing on things that we really don't want pushed on. Some pupillary changes. We like nice, round, regular pupils that react. Reaction is always good. Excuse me. Irregular pupils, if we can get a history from them, have they had cataract surgery? Have they had corneal implant? Or is it a new injury to their eye? Somebody gets whacked in the eye and they could have an injury to their pupil from that. Oval pupils. Anybody seen oval pupils on a patient before? I've seen it a few times. What that is indicative of is if you go from a nice round reactive pupil to all of a sudden your pupil is starting to change its shape just a little bit, but nothing else has changed, you know that they're getting more pressure on their third cranial nerve because occasionally it can disrupt that parasympathetic flow to the eye and cause their pupil to become oval like that. So if you see that, that's something that should probably be reported to the surgeon right away. And we all chart PERLA. Does everybody know what pupils equal round reactive to light with accommodation means? Okay. It took me a while to remember that one too. Accommodation is when you're looking far away, your pupils are dilated a little bit. When you look up close, they constrict.
We can't really test that a lot of times.
We can't. We can't. But if you have a patient that's awake, you can check that. For a while, I always used to think, as long as both pupils constricted at the same time when I shined a light in them, that was accommodation. It's not. That's the consensual response of both pupils, but it's not accommodation. So, just like to make sure everybody has those down. And then our pupils respond to, I mean, they're in that sympathetic / parasympathetic loop. And so, you know, the fight or flight thing, if somebody was to come in here and sneak in the door and pop a balloon, all of us would jump and our pupils would dilate because the sympathetic response, and vice versa. The parasympathetic response causes them to constrict, and so that'll be important here in a little bit when we talk about some other stuff. So pupillary changes that you may see, if we were all outside on a sunny day, our pupils would be small and reactive. That's normal. In the setting of a known head injury with a lesion of whatever type in their brain, and they've had normal sized pupils that are reactive, and all of a sudden, for no apparent reason, their pupils become fairly small, but they still react, you're probably getting a little more pressure on the midbrain and the diencephalon. And the reason that they're becoming small is because that sympathetic portion of that feedback loop to your pupils is getting squeezed, and the parasympathetic response is taken over. And so, again, if you have a pupillary change like that, it's easy to overlook this one. in particular, because they're still reactive, and we always think of brain injuries as being dilated pupils, but if you have a sudden change to this, don't overlook that. We talked about the uncal herniation with unilateral fixation, dilation. Again, that's just it's pressure on that third cranial nerve, and that is when you'll see that, just one side being like that. Talk about medications, excuse me, and drugs a little bit that cause some of this. Bilateral dilation and fixation. What are some of the drugs that we commonly give people? One of the drugs in particular that can cause that.
Dilation?
Yeah.
Epi?
Epi can. What's even more common? How about atropine?
Atropine.
Yeah, atropine. So, particularly in a post-arrest patient that you're trying to do a neuro exam on, if they've gotten atropine or even 1 or 2 doses of atropine, your pupil exam for the next 6 hours or so is
that long.
kind of not worth a whole lot, because they're going to be fixed and dilated. And that goes back to that parasympathetic response. How does atropine work? I know we give it and the heart speeds up. So what it does is it blocks the parasympathetic response. So when we give it for a cardiac patient, we block the vagal / parasympathetic response, and then you have sympathetic response goes wild. And that's why the heart speeds up. And so the same thing goes for our pupils. When we give atropine, we block the parasympathetic input to the eye, and so you have sympathetic nervous system gone wild, and the pupils dilate and they just stay there. So that's why you may see that. Some of the other things that cause that is LSD, coke, meth, hallucinogenic mushrooms. I know none of our patients are on any of that stuff, but you may see that.
So they actually fix and dilate?
I've seen people, particularly on overdoses of meth, that their pupils are so dilated that they don't die. Yeah. In fact, we had a good guy down in, 39? I think he's still there.
Yeah.
He came in
Okay.
yesterday morning tweaking unbelievably. And you could see his dilated pupils from across the room. I mean, he was just like, whoa. So if you have mid-sized pupils that don't react, again, that's all of these pupillary changes are because the third and sometimes the sixth cranial nerve is being compressed. So you may see all or a combination of these at different times. The big thing to remember is that if there's a change, we want to do serial neuro exams, and if there's a change in their pupils, that's when we need to start getting more concerned. Note what they are when we first assess the patient, but then if there's a change, we need to be aware of that. Pinpoint pupils. Most of the time that I've seen a patient with altered mental status come in with pinpoint pupils, it's been a pontine hemorrhage. They bleed in their brainstem, and they have pinpoint unreactive pupils, and it's kind of game over. The only other thing that you may see pinpoint pupils from, obviously, is opiates, and alcohol will cause the same thing sometimes. Not so much pinpoint, but constricted. But if you get a report of it, your patient report is that the patient suddenly went down and became unresponsive, and they have pinpoint pupils, I could almost guarantee it's going to be a bleed in the pons. The hippus reaction is one that we don't hear a lot about, but it's something that we need to know about and report immediately if you see that, because what you'll see is your patient will have normal, equal reactive pupils. Everything looks good, and then the next time you assess them, their pupils constrict normally, everything's good, and then all of a sudden you'll get this spasming of the pupil, big, little, big, little, big, little. And that's an early sign of compression of the third cranial nerve, and it's something that needs to be reported to the neurosurgeon immediately, because they may want to intervene as quickly as possible to keep that pressure from getting any worse. The only other way you may see this that I've been able to think about is with plants, some plants, alkaloids that are really poisonous to people.